Good evening, everybody, and welcome to the Personalized Lifestyle Pearl session that we're having tonight. As you know, every month we have a special speaker speaking on some designated topic, and I feel like tonight we're all going to learn a lot. We're going to be talking about a very specific condition and a very unique protocol for it. So I'd like to welcome Dr. Karima Hirani.
Thank you.
Great to have you here, and I'm glad you got on okay. What I want to talk just a little bit about her bio and what she's done, because it's quite profound. She has sent me a lot of information before our session, so I've had some time to read up on. She has a case study publication. She's done a lot of different things, and she's been in practice for decades now. Dr. Hirani is a medical doctor and also has a master's in public health. Such a great combination. So the fact that she's board certified in family medicine, integrative and holistic medicine, she complements that very well with her clinical homeopathy degree. She received her medical degree from the Keck School of Medicine of USC, and she completed her family medicine residency at Long Beach Memorial Hospital. She also received her MPH from UCLA School of Public Health and completed an international certification course in ozone therapy. So she's truly integrative, bringing in her family medicine, ozone therapy, homeopathy for a beautiful blend in order to personalize with her patients. So currently she has a practice in Culver City, California at the Hirani Wellness Medical Center. So hello, Dr. Hirani. Glad to have you, and quite the bio that you have.
Well, thank you so much. It's an honor.
So tonight we are going to be talking about something that I think is, it's not something that everybody hears about all the time, right? We're going to be talking about PANDS and PANDAS. And let me just spell out what that acronym represents. So pediatric autoimmune neuropsychiatric disorder associated with streptococcal infection. And typically this happens in the pediatric population. But you've also seen some cases in which we see this in adults. So maybe talk generally about PANDS and PANDAS to just get us all on the same page as far as definition, what does this look like clinically, and then we'll get into your therapeutic approach.
Okay, so I've been treating autism and children with neurodevelopmental disorders since 2001, so a long time now. And they would occasionally present, with OCD and, anxiety and tics, and we just really didn't know what was happening. And a while ago, just a few years ago, we started learning about the concept of PANDAS, which again you described as pediatric autoimmune neuropsychiatric disorders associated with strep infection in children. So the condition is episodic, and it's usually a very sudden onset of obsessive compulsive disorder, and it can have tics, involuntary movement disorder associated with it. And this is usually following like a strep infection. However, not every child will have the history of a classical, strep infection, because, as you might know, a lot of these cases, people are asymptomatic and they're just walking. They're chronic carriers of strep, and they don't even know that they have or they've had strep in the recent past. They can have motor and vocal tics, and the hypothesis is that the PANDAS arises from the development of these brain-reactive autoantibodies after the group A streptococcal infection. And PANDAS may meet the criteria for PANS. So after learning about PANDAS, we started learning that there's a condition that's a more broader, as far as, diagnosis goes, it's more broader and it's more inclusive, and it includes other potential infectious triggers as well as environmental triggers. And that's where the PANDAS definition comes in. So the PANDAS definition is pediatric acute onset neuropsychiatric syndrome, which is also like a sudden onset of OCD. But it could also have food restriction as part of the diagnosis. And it includes two, in addition to the OCD or the anorexia, it will include 2 out of the 7 following comorbid conditions. Anxiety is one of them, depression is one of them, ADHD or deterioration in school performance, irritability, aggression or severe opposition, sensory or motor abnormalities. So this is where for example, the urinary frequency or the urine accidents, the sleep disturbances, the involuntary motor movements, and then memory or cognitive deficits. So, so the trigger for PANDAS is usually infectious or inflammatory. And diagnosis, is very helpful to try and minimize the symptoms, but the treatment should begin simultaneously. And in my practice, the testing that I do for PANDAS will include, of course, the PANDAS testing, which is, a rapid strep or a strep culture, and then the antibodies for strep. But I'll also test for various different infectious organisms like Lyme and Mycoplasma and Epstein-Barr and CMV and many others. And I, excuse me, and I do see, when I do the lab work, I do see a lot of IgG antibodies, which, indicate past infections, but I also will see a lot of IgM positive. And in fact, in children that have been vaccinated, which makes up a lot of my pediatric population that presents, I will sometimes see IgM positive varicella or measles or mumps or rubella, because these vaccines were live viral vaccines. So sometimes I will see even IgM positive Lyme or IgM positive EBV. And so so that's how we get started. Of course, I also look for environmental toxins as well. Anything that is going to cause inflammation to the brain, to the central nervous system. So remember, the trigger is either infectious or it's inflammatory. So I do see a lot of heavy metal burden in these children, and sometimes we also find mold toxicity.
So interesting. Just to let you know, we've got a number of people who have signed on to let us know that they're here. We've got a PANDAS mom and health coach. We have a psychiatric physician assistant and functional medicine PA. We also have a pediatric psychologist working in the area of pediatric feeding disorders. So we have a very interested group of viewers. Now, the focus, as you've described it, has been primarily pediatric. What types of symptoms might you see in adults, and what would trigger you clinically to start thinking about PANDAS, or perhaps the P needs to be replaced because that has to do with pediatric, but how might you be thinking about these symptoms, this cluster in adults? How does that manifest? Is it your first go-to, or is it somewhere down the line after you've looked at a number of other things?
I'll give you a case of a patient I just saw last week, a 25-year-old young man who presents with a history of OCD, anxiety, ADHD, sleep disturbances, severe tic disorder, classic PANDAS symptoms. And he unfortunately developed most of these symptoms when he was in second grade. He was 7 years old. And it started off with the ADHD, and the teachers told his parents that he's got, he needs to be on medication. He's got ADHD, and they chose not to. And so this is a case of a child that was not properly treated. And back then, I don't think anyone even knew that PANS existed. And so he's sort of disabled. He can't function. He's addicted to marijuana. He's addicted to Xanax. He can't function in school. He went to college, dropped out. Meanwhile, his sister is an attorney, so he's extremely smart, but he's just not very functional. So I see cases like this a lot, and it's rather unfortunate because, children even today that have, the classic PANS, they're not being properly diagnosed because even though, as I sent you the consensus paper on PANS and PANDAS, it's not the standard of care. So a lot of pediatricians, a lot of psychiatrists, they're not really, most times they're not even aware that this condition exists and that, it can be treated. So I see this a lot in my practice with adult patients, and the treatment for me is the same. They obviously come to me because they don't want to do the ADHD drugs or the anxiety drugs or the medications for OCD. They really want to get to the bottom of why they are feeling the way they are. And so my approach is really identical as I would for
your
kids.
approach, which I've had some time to review. You've got many different pieces and parts to it. Perhaps you can take us through each one and how you would determine what to use when.
Okay, so I think what I'll do is I've just made some notes here if I may use them, because what I'll do is I'll give you kind of like a snapshot of the different types of treatments, and then I'll kind of go through the individual types of symptoms that these children present with, and perhaps if you want me to tell you a little bit about the conventional approach, and then how I would approach it, we can do it that way. So I'll start with just basically telling you that first I do a very thorough workup. So I mentioned to you I do an infectious disease workup, but in addition to that, I also look for nutritional deficiencies. I look for environmental toxins. I look at hormones too. I look at thyroid. I look at adrenal and growth hormone deficiencies in my pediatric population. And so I'm just checking.
If we can just go to the nutritional status, because it's quite rare to find a medical doctor who does nutritional medicine. What are some of the things that you're looking at when you're looking at nutrition? Are you doing lab testing where you're looking at certain vitamins and mineral levels?
Yes. So I look, I don't know if you mentioned this to your audience, but I do have a degree in nutrition from School of Public Health at UCLA. So I am kind of very attuned to the importance of nutrition and health. So I do check for omega-3 fatty acid deficiencies. I check for vitamin D. I check CoQ10. I check for B12 deficiency using methylmalonic acid. And I'm trying to think, of course, iron. I check for zinc deficiency, and checking for zinc is a little bit, tricky because there's a school of thought that believes that just serum zinc alone isn't enough. You need to look at the serum copper levels, and then you need to put them in a ratio. So those are some of the nutrients that I'm looking at. I also look at food allergies. So I find that this population of patients, they have a lot of food allergies or inhalant allergies. They may or may not present with a history of seasonal allergies or food intolerances or sensitivities, but then when I do the lab work, I find that, they in fact do have food allergies or food, sensitivities or inhalant allergies.
Great. And that makes sense, right? Being that the gastrointestinal tract is the seat of the immune system, it would seem that the two would go hand in hand. Are there certain food allergies that you find to be more common in this group than in others? Or is it just the standard looking at wheat, corn, soy, sugar, not as an allergy, but just as something that these children probably react to and they're more sensitive?
I do see a lot of wheat intolerance, gluten intolerance. I see a lot of that. So one of my first approaches to patients that come to me with this kind, with this kind of presentation, adult or pediatric, is the gluten-free, casein-free diet. Low sugar or sugar-free, organic, non-GMO, preferably corn-free, soy-free as well. And I find that this diet, it may seem daunting to some patients, but once you do it, you find that it's not too difficult to do, and it can, it can have great results. So we see a lot of improvement in anxiety in my patients. The OCD can get better by just removing these foods. I think what we need to educate our patient population on is how inflammatory these foods actually are, unfortunately. And you might ask, well, why are these foods so inflammatory? I'm sure that this is something that you've probably talked about, you've probably thought about, and I'd love to hear your take on it. I'll give you my take on it. I feel that the use of pesticides has just skyrocketed. The way that we've adulterated our food. For example, the wheat is so hybridized. So I think these combinations of things where we've put a lot of GMO and a lot of pesticide use, and then we've modified these, hybridized these foods. We're just not eating really healthy food anymore, and these foods, unfortunately, are just the most inflammatory. And remember, one of the triggers for PANS and PANDAS is inflammation. So we want to do whatever we can to reduce the inflammation. So that's like first and foremost. That's like a given that, I ask every patient, to go on this diet. Oftentimes parents have already done this and they've already seen improvements in their child. And that's why they want to come to a doctor who is providing, this kind of, functional medicine, biomedical treatment for their children. And one of the other really effective tools, really simple to do, is the methylcobalamin injections. I don't know if you have any experience with that, but the methylcobalamin, I explained to parents and my adult patients, that very harmless. There's no toxicity with it. It's very easy to administer. It has to be injectable because the oral doesn't seem to have lasting effects. Being water soluble, the B vitamin, when you take it orally, you absorb what you need for that moment, and then you pee the rest of it out. When you do the injectable, you're creating a deposit, which seems to keep up with the body's ongoing need for either methylation or for the methylcobalamin itself, because we do find methylcobalamin deficiencies in these kids as well. But methylation seems to be also an issue. And that's another part of my testing that I do, which is testing for methylation defects. And I do see it. 40% of the population has methylation defects. So it's not surprising that, I see a lot of that in my practice. So those are some of the two things that I start off with. And that's, I like everyone to try the methylcobalamin because it's so harmless. And I warn parents that, the child may get a little hyper from it. If it's just a little bit of hyperactivity, deal with it. The body will settle down. If there's a lot of hyperactivity, the child is going bonkers, then you need to stop it and notify me. That usually is a sign to me that there's probably a lot of dysbiosis going on in the gut, and that we need to work on, cleaning up the gut first. So those are two of the first things.
We're getting a number of comments, which is great. Many people signing on from different areas. So somebody's asking what type of injection. So that was a methylcobalamin injection. How often would you give injections to children then of B12 in this format?
So the methylcobalamin is prescribed twice a week, and the way it goes is it's about 64.5 micrograms multiplied by the body weight in kilos. I mean, let me, because I'm a little nervous right now, so I want to make sure that I'm doing this right. So it's the kilograms. So you get the child's weight in kilograms, and then you multiply it by 64.5. And that's the dose in micrograms that you're going to give. And the dosing is usually about 1,000 micrograms or about 1,200 micrograms, and that's given twice a week, okay. Subcutaneous actually. We don't do it intramuscular, so it's a very tiny insulin syringe that we use. It's the the BD syringe, very short, ultra fine, and it's subcutaneous in the hip. And I tell parents that if the child responds really well, then you can actually go to every other day. So this is now from twice a week to 3 times a week to actually even every day, because there's no toxicity with the methylcobalamin. So yeah, so when it comes to ADHD, so that's one of the symptoms that we talked about, right? So when it comes to ADHD, the methylcobalamin can really help with the focus. When it comes to anxiety, when it comes to depression, the methylcobalamin can really help with that as well. So that's why, I see it kind of like a panacea, but it really can be like a panacea. So it's something that you should be thinking about trying, because there's really no downside to it. There's no toxicity.
And if the levels are normal, though, then there's no need for the sub-Q injection, or do you feel like maybe the body is just not able to absorb and get it in, and so maybe having the shots would be important?
So you have to remember, when it comes to B12, serum B12 levels, they're not considered to be very accurate. So you want to be looking at methylmalonic acid levels. But sometimes even the methylmalonic acid levels will be normal, but we gave an empirical trial of the methylcobalamin injections, and the child improved. So you can't rely just solely on the B12 levels or the methylmalonic acid levels. So I encourage you not to just rely solely on levels.
That's a great point. And one other question before you go on in your therapeutic approach that I don't want to lose, from Megan. Megan is a PANDAS mom diagnosed at the age of 6 who has a child now, not 10. What is the lasting effect throughout life if they are treated?
Can you say that again? I'm sorry.
Sure. So there's a PANDAS mom who's asking about their child diagnosed at the age of 6, and now the child is 10. What is the lasting effect of this throughout life if they are treated? So if they're treated at the age of 10, are we going to see any repercussions in their adult life? Will they be more prone to things like anxiety, gut dysfunction? Well, we always have to have certain things on the radar to monitor in their adult life. Will they have more susceptibility? I don't know if you've seen children who have then grown into adults where you've seen lasting effects and you have to kind of corral them back with different clinical therapies, or if you work on it during their childhood, if it resolves. And probably it's very individualized.
Yeah, I mean, that's a tough one to answer, and I'll tell you why. Because first of all, there's variations of degree of severity. So some children present really mild, and all they need maybe is just a course of antibiotics, for the PANDAS, and they're good to go. But then they may later on present with severe OCD and anxiety and things like that, and the antibiotics are not working now. So that's the one thing you need to understand with PANS and PANDAS, is that the course is remitting, relapsing, and so it's up and down and up and down. And when you say the child has been adequately treated, You know, I question that because, you know, what do you mean, you know, was the child adequately treated? Did you just do a diet and you did some supplements and the kid got better? Did you go to a biomedical doctor? Did they find heavy metal burden? Did you do the heavy metal detoxification? Did you, you know, did you treat the allergies? And then also remember, one of the things in the article that I hope that your audience has read is that, you know, CBT is very important. So cognitive behavioral therapy in children that have, you know, severe cases of this, if they start the CBT early on in the course of their illness, they will learn lifelong tools to be able to handle their anxiety and handle their OCD, you know, without having to revert to medications. So it's a tough question for me to answer. But I hope that I was able to give this mom some.
Oh, I think your answer is spot on, because it really does depend on how it was treated and, like you said, the severity. Dr. Hirani, can you talk a little bit about, well, one of the things that I did mention in when I was introducing you in your bio is your case study that was published last year in 2018. Can you talk, if you'd like to talk about this case, that's fine. This case, it looked like you were looking at ozone therapy. And I'm kind of curious, because oxygen has become, I call it I refer to it as a nutrient. I mean, our body does need oxygenation, proper oxygenation. We don't want too much because we can get oxidative stress, and we don't want too little. And so how is ozone therapy, how is bringing in more oxygen to the body therapeutic for these kids and even adults?
Well, I am so excited to talk about ozone. So what I would like your audience to know is that ozone was discovered in the 1800s in Germany, and ozone in Greek means bad smell, because that's what it is. It's a bad smell. Fast forward till 2019, there's been more than 3,000 publications on ozone, mostly European research. What your audience should also know is that ozone was widely used in the US around the turn of the 1900s. It was used in medicine because it has so many applications. It was also used in World War I to treat trench foot. So this is all historical, and anybody can look this up. So what does ozone do? Ozone has two main actions. One is in pain, actually. So when we inject ozone, in joints, in acupuncture-like fashion, where people have actual trigger points or tender spots, it literally turns off the pain receptors. So it can literally turn off pain. So that's one of its mechanisms of action. The second mechanism of action is it stimulates in your body your own production of your antioxidants and antioxidant enzyme systems. So remember going back to PANDAS, and I told you that the trigger is inflammation. When you can produce your own antioxidants in your body, these are antioxidants that are dormant, and the ozone is just waking them up. You are able to reduce inflammation. So I've just seen wonderful things with ozone. I feel that it is a highly underutilized, amazing tool that we have in our hands as physicians. Because there's so much research that's been published on ozone, the safety and efficacy is well established. Nobody's allergic to oxygen, so you don't have to worry about allergy to ozone, because ozone is made up of 3 oxygen molecules. So I have great results with ozone. I use it in the pediatric population. I use with the speculum, with the ear. So we do the ear. We can do intranasal. We do rectal. I've had a little girl who has recurrent yeast infections, and she's only 6 years old. And we've done vaginal ozone on her. And, you know, it's a very small little catheter that we insert inside her vagina. And the ozone is just flowing, you know, flowing into her vagina over the 10 minutes. So the ozone can be given intravenously, which I love to give. If the child can sit for about 40 minutes, I love to give the intravenous ozone. There's two types of intravenous ozone. There's the major autohemolytic, where we actually have to take the blood out and then mix it with the ozone and then infuse it, you know, back into the patient. But what I've learned from the course that I took in Spain is the saline ozone is far more effective, and it's just less cumbersome. You don't have to take any blood out. It's just saline that's bubbling. The ozone is bubbling into the saline, and then it's, you know, given intravenously. So it's much easier, you know, to give to the patient. And then in this case report that I did, this child presented, a 2-year-old child presented with speech delay, and he was IgM positive for CMV. But what I didn't mention, and I'll share with your audience, is that he was also IgM positive for measles, for mumps, and for rubella. So he was IgM positive for 4 different infections. So we started the ozone IM injection, so intramuscular injections, where we draw 5 cc's of blood. So it's like doing a venipuncture, like a blood draw. And he came, and we would mix that with 5 cc's of ozone, so equal amounts of ozone. And then we give him the blood back, just the ozonated blood. You don't have to give the remainder of the gas that's in the syringe, but just the ozonated blood, which has been mixed for about 30 seconds. And we give that to him intramuscularly in his hip. So he came and he did 8 of those injections. And even before the course of the 8 injections were done, he had improved clinically. So the parents were really thrilled with his improvement. And he seemed healthier. He just wasn't getting as sick anymore. So we were really pleased, because even before we finished the course of the 8 injections, we tested his blood again, and he was already pretty much turned off of all 4 of them. I think 1 was remaining, and that was the CMV. And in case your audience doesn't know, Cytomegalovirus, when the fetus is exposed to it in utero, can cause neurodevelopmental disorders. So I suspect that the CMV was probably doing more harm than the other 3 bugs were. But after the 8 injections were done, we retested him again, all 4 infections, and we were able to demonstrate that he was no longer IgM positive for these infections. So that's my experience with with this publication. It was really exciting, because there's not a lot of research that's been done in pediatrics and in ozone. But as I said, it's very safe. It's highly underutilized. Don't be afraid to use it. Check out AE Promo if you want to learn about ozone through this organization, and you can take the course. So that's
that was the only therapy that you used with him.
I'm sorry, can you say that again?
That was the only therapy that you used with this particular case?
That I published on, but no, he's still my patient. And that brings me to 2 other very, very important and very successful tools that I have in my practice. So one of the things that we're doing for him now is we're doing the transdermal chelation, where we apply the topical chelation cream. So I tested him for heavy metal burden, which is the urinary porphyrins test that I did, and it was positive. So we started him on the transdermal chelation. And again, this is a very gentle, non-invasive process that I use on a lot of my children, and a lot of kids, you know, benefit from it. So he has done that. He's in the process of doing that. Another very successful tool that I utilize is low-dose immunotherapy and low-dose allergy therapy. And I am very fortunate that I get invited to Autism One, and I speak on these topics. And if anyone is interested in learning more about LDA and LDI, they can go to my website. I have posted on there my previous lectures that I've given over the last 3 years, and I'll get to go again this year in May, and I'm going to actually speak on ozone as well, and stem cells as well. So
you're really cutting edge.
Well,
I would say, you know, what I really like about you is that you're evidence-based, and yet not afraid to try new things. Or maybe these things aren't even new, but they're new within the guise of science and really being looked at from a method perspective. So it's really exciting to hear you speak about all these things.
Thank you. Yeah, the low-dose immunotherapy that this little boy is getting, even as we speak, is based on the IgMs and the IgGs that were positive on the infectious disease testing. So he's obviously gotten the CMV LDI, he's gotten the MMR LDI, and some other ones that he was positive for as well, but not IgM, but IgG. So I look at both. So as a physician who's interested in learning about low-dose immunotherapy, you want to look, in the way I do it, is you want to look at both the IgG and the IgM, and whatever comes up positive, then that's what you want to treat with. So let me tell your audience really quickly what LDA and LDI are in a nutshell. So LDA has been around for about 50 years, low-dose allergy therapy, and it's a homeopathic dilution of hundreds of foods and chemicals and mold and more. And it's given under the tongue, sublingually, and it can really just literally turn off the allergy. So you're training the immune system to build tolerance. So it's a form of allergy desensitization without having to do the allergy shots. And the allergy shots that you get at the conventional allergist office they don't touch foods, they don't touch mold, so they're very limited in what they can desensitize the child with. So the LDA, I find, is one of the first things that I actually prescribe. So if a child presents with PANS or PANDAS-like symptoms, if I did the rapid strep, and if the rapid strep was positive, then one of the first things I would give would be the strep LDI. And I'll talk about LDI in just a second. But if the LDI was not, if the strep, rapid strep was not positive, then I would probably give the child the LDA drops. Because like I said, the child does not have to have typical seasonal allergy symptoms of runny nose and sneezing and coughing, or typical food allergies. His sensitivities or allergies may be asymptomatic. So I treat, and when I treat with the LDA, I will see improvement in a lot of the OCD sometimes. So I definitely want the clinicians to be looking at allergies and food sensitivities. Remember, they cause inflammation. Anything that causes inflammation is going to trigger the PANS. And then the LDI is low-dose immunotherapy. And Dr. Ty Vincent, he's an MD, a family physician. He's credited for discovering low-dose immunotherapy. And it's a very new treatment, so it's considered experimental. I learned about it at a MAPS conference, so I encourage your physicians and nurse practitioners to attend the MAPS conferences, the Medical Academy of Pediatric Special Needs conferences, because you'll hear great speakers. And Ty Vincent spoke there in 2015, and it just resonated with me like nobody's business, because I felt like autoimmunity was one area that we don't have a handle on. We don't really have anything to really give to these children. And the LDI was this amazing tool that addresses just that, you know, the autoimmune aspect of this chronic illness of PANS and PANDAS. And so I do the lab testing, and then whatever I find on the lab testing, I will give to these children. And again, these are homeopathic dilutions. Do you think everyone in your audience knows what homeopathy is?
Why don't you just give us a quick thumbnail of homeopathy?
Okay. So homeopathy is based, again, another German tradition. It was Dr. Hahnemann discovered homeopathy in the 1800s, kind of like ozone. And in fact, there were homeopathic medical schools here in the United States, and they were growing side by side with medical schools. But unfortunately, they got stamped out for no good reason, and now they're just not even talked about, unfortunately, in modern medicine. But homeopathy is based on the concept that like cures like. So I think Dr. Hahnemann, he was not very happy with medicine, and he decided to start translating textbooks. And he was translating one textbook, and it talked about the cure for malaria was quinine. And he somehow decided, well, if quinine can cure it, I wonder if maybe if I could dilute it, it would do the same thing. Well, it did. He found that if he made dilutions of it, you can also get the same results as the actual quinine by itself. And in fact, I've done that with medications. I have done that with Vyvanse, which is an ADHD drug. I've done that with Ambien, which is for sleep. And so I make these homeopathic dilutions just like Hahnemann did. And these dilutions they're so dilute that there's not even a trace of one molecule in the sterile water. And I'll give you an example of how that works. So imagine you've got your mother tincture, you've got the actual, let's say we're making the strep LDI. So you order from a microbiology lab the killed strains of, group A, and we've got the group B strep, and, all of the different streps, and you have it in this vial, and these are killed strep organisms. And then you take from this vial 1 drop, and you put it in a vial of just sterile water now, and it has that 1 drop from the actual mother tincture, and you shake it up. Now this is called a 1C dilution, and you take 1 drop from here and you put it in another 10 cc vial of sterile water, and now you have a 2C dilution. So you went from 1 part of strep to 100 parts of sterile water. Now you've gone to 1 part to 1,000 parts of sterile water. So as you keep making these dilutions, pretty soon you'll get to a point where there's not even a single trace of the actual bug left. What you're dealing with now is the energetic imprint of that bug, and that's what we give to the patient. And that energetic imprint has a way to communicate with your immune system, with the T regulator cells under the surface of your tongue, to then go and tell the rest of the immune system, hey, do you see this bug? Yes, you see it. Okay, this is friend, not foe, so back off and stop attacking. And all of a sudden the immune system listens, and the OCD gets better, the anxiety gets better, the anorexia gets better. So many symptoms can improve by just giving the right dose of LDA and LDI. And if your audience, the physicians, are interested, they should contact Ty Vincent. He has a manual, which I ordered immediately after I heard him speak. And I read that manual like 5 times. And when you order the manual, you get all of the dilutions that he's made of strep and CMV and EBV. And you get all of these dilutions. I made some myself. I made my own MMR. I made my own varicella. And like I said, I've made one for glutamate, which is from MSG, because glutamate is very excitotoxic neurotransmitter, causes inflammation in the brain. So I have good results with glutamate. I have good results with he sent me a marijuana LDI, and he made that for a patient who had allergies to marijuana, but I use it like Dr. Hahnemann used it. I used it in a very low dose to provide the benefits of marijuana, which is a calming effect, improved sleep, improved OCD. So I do that. So I have a lot of my own, but I get most of the bugs. I get them all. The parasites, the yeast. I get that all from Dr. Ty Vincent. So I've spent a lot of time talking about LDI and LDA, but it is one of my most effective tools in my practice because this is what parents want. They want to come and do something that's, benign, fairly benign, and and potentially curative.
Yeah. Well, and just looking at the comments here, it seems like there's quite a lot of interest in Buzz. I know that we've gone 15 minutes over. We do have a number of people on. I think what I'm seeing as far as the comments go is people want to know action steps. So they want to know, like, where do I find a physician who can work with my children or child? What are some basic resources? How might we direct people who need help if they need to address PAN or PANDAS in their children?
So I think the MAPS, the Medical Academy of Pediatric Special Needs, I think they do have a referral, a provider list.
Okay.
So you can go there. I think I think I'm on there. I think there's a PANDAS network that also lists physicians there, and I'm also on there. So I'm sure that there's other holistic physicians that are on there. And you have to remember that every physician, I feel like medicine is an art, yes. And every physician is going to bring to the table, whatever, resonates with them. So you're not going to get the same, everything that you're hearing today from me, you're not going to get the same approach from another physician. So just remember that and be open to that. But I think those are two ways that I think you can find doctors that are treating children with these kinds of conditions.
Fabulous. And some of you are questioning the papers that we discussed. Those have been uploaded to the comment thread. So find those links there. So Dr. Hirani, this has been excellent. I've learned a lot. This is really a fascinating area of exploration. It's fairly new, it's emerging. The research is still evolving. And so you're part of this, I would say, from your own clinical experience, and what you brought to the table is quite unique, how you've synthesized a very effective therapeutic plan that you personalize to each of your pediatric and adult patients. So thank you so much for sharing your wisdom. I feel like this has been a real eye-opener for so many of us. And I'm sure that the questions are going to continue on this thread, which they can. We'll do our best to get to those. So Dr. Hirani, thank you again. It's been a pleasure.
Oh, it's my pleasure. There was so much more I wanted to share with you, but there's just not enough time. So maybe you'll invite me again and I can talk some more.
We'd love to have you back. Absolutely. Thank you so much. And thanks to everybody for being on with us and adding in your comments, your questions. They really help to fuel our discussion further. So I invite everybody to join us next month in February when we'll have Dr. Sarah Godfrey talking about anxiety. So thanks, everybody. Have a great night. Take care. Bye-bye.